Good morning, everyone. Today I'll be presenting the third part of the ART series of lectures. Sharpening of the spoon excavator. Now we have to place the round surface of this excavator in the oil and make small strokes in the center of the round surface to the edge of the spoon. Do this in all directions so that the entire cutting edge is sharp, as you can see. Hygiene and control of cross infection. If available, always wear gloves. Cleaning and disinfection of the working place and sterilization of instruments is essential to prevent infection passing from the operator to patients and vice versa, or between patients via the operator. Cleaning and disinfection of surfaces in the working place can be done by using cotton gauzes impregnated with methyl spirit or alcohol. In a clinic, instruments can be sterilized in an autoclave or a pressure cooker. If not in the clinic, a pressure cooker or a pan with a lid to boil the instruments can be used. To avoid the risk of infection with diseases such as human immunodeficiency virus (HIV) and hepatitis B, all instruments must be sterilized before being used for each patient. Now coming to the operator's work posture and positions, the operator should sit firmly on the stool with a straight back, thighs parallel to the floor and both feet flat on the floor. The height of the stool should be adjusted so that the operator can see the patient's teeth clearly. Oral care is best provided by a team consisting of an operator and an assistant. However, assistance may not always be available. The assistant works at the left side of the right-handed operator and does not change position. The patient should lie flat on a surface that will provide safe and secure body, support in comfortable and stable position for lengthy periods of time. Patient's head position is a backward tilt, lifting the chin for access to upper teeth, and forward tilt, dropping the chin for access to lower teeth. The range of positions that are used are 10 to 1 on the clock, and most commonly used positions are direct rear position 12 o'clock and right rear position, that is 10 o'clock. Monitoring restoration and sealants. No restoration or sealant, irrespective of the material used, lasts forever. Some restorations may last for many years, others may fail earlier. Ask patients about pain felt during and after treatment and their overall satisfaction within a period of 4 weeks after being treated. First clinical evaluation should be done after half a year. Further evaluation on an annual or a biannual basis depending on factors such as expected caries development and the possibility of sealing the individuals again. For failed or defective sealants, examine the tooth carefully for signs of caries. If the surface is hard, leave it alone. If the surface is carious, reseal or make a small restoration depending on the extent of the defective sealant or of the caries present. A restoration may not be acceptable or unsatisfactory when it is completely missing. A large part of it has broken away, the restoration is fractured. Much of the restorative material has worn away, caries are developed at the restoration margin or elsewhere on the tooth surface. Whatever the reason, it is important to clean the cavity completely, apply dentine conditioner and refill the cavity according to the description. Use of easily available and relatively inexpensive hand instrument rather than expensive electrically driven dental equipment. A biologically friendly approach involving the removal of only decalcified tooth tissue which results in relatively small cavities and conserves sound tooth structure. The limitation of pain, thereby minimizing the need for local anesthesia. A straightforward and simple infection control practice without the need to use sequentially autoclaved handpieces. The chemical adhesion of GIC reduces the need to cut sound tooth tissue for retention of the restorative material. The leaching of fluoride from GIC prevents secondary caries development and probably remineralizes the caries dentine. The combination of a preventive and restorative treatment in one appointment. Restoration can easily be repaired if damaged. Low cost ART may be used to restore and prevent caries in young patients, uncooperative patients, or patients with special healthcare needs, or when traditional cavity preparation and/or placement of traditional dental restoration is not feasible. ART restoration can help maintain natural tooth eruption pattern and avoid disturbances in the position of permanent teeth. The long-term survival rates for glass ionomer, ART restoration, and sealants are not available. Limited to small, medium-sized one-surface lesions. Uh, It is used because there is a low wear resistance and strength of existing glass ionomer materials is high. Hand mixing might produce an improper mix, varying among operators. Misapprehension that ART can be performed easily. This is not the case, and each step must be carried out with perfection. Possibility exists for hand fatigue from the use of hand instruments over long periods. Treating dental caries using the ART approach without emphasis on preventive measures is a job only half done. Important to explain to people how they can prevent dental caries from affecting other teeth. removal of plaque, counseling on proper diet, application of fluorides, application of antimicrobial agents, and application of steroids. The ART approach was pioneered in Tanzania in the mid-1980s, which was followed by several community field trials conducted in Thailand, Zimbabwe, and Pakistan in 1991, 1993, and 1995 respectively. Results of the studies in Thailand and Zimbabwe have shown that 71% and 85% of the ART restoration remained in the teeth after 3 years. Studies conducted in several countries showed high survival rates of atraumatic restorative treatment, one-surface restorations, even in comparison with amalgam restorations, median survival time of atraumatic restorative treatment, which is 5 years compared with 7 years for conventional amalgam restorations. The cost effectiveness of atraumatic restorative treatment has also been established, considering costs of equipment, material, and wages. Atraumatic restorative material is currently used in 25 countries and is part of the regular training programs for oral personnel in at least 3 countries.